Hello, everyone. Welcome. This is the session on medically challenging cases. We have some oral abstracts, and I think hopefully we have all the presenters with us. I think we have 4 of these, right?
We have 4 of these, yeah.
Okay, and each one is given 15 minutes to present. And the first one is from Vanderbilt University, acute cardiac allograft rejection treatment via plasmapheresis with inadvertent whole blood volume replacement and hypoxic PEAE arrest in an orthotopic heart transplant patient. Is Dr. Subasish Bhowmik? I apologize if I mispronounce your name. Please come up to the podium.
Thanks, guys. And yeah, as you all know, we just went through the title, but yeah, excited for this presentation. Thanks for having me. And we're about to go to the next slide. I don't have any financial disclosures or any other competing interests. There's a clicker up here?
Yeah, the green arrow, I think. You probably pointed at that.
There we go. All right, just getting started with our case. We have a 50-year-old female who's 10 months status post from orthotopic heart transplantation. She came in with acute allograft rejection with acute heart failure. And then on hospital day 2, she ended up getting worsening biventricular failure, severe on both sides, and then increasing filling pressures and new onset VTAC. With all this changes on hospital day 2, we then cannulated for peripheral VA ECMO with an Impella for LV venting. From the beginning, we started off with acute rejection treatment with plasmapheresis, thymoglobulin, and pulse dose steroids. She continued on mechanical circulatory support as we continued acute rejection therapy. During her last plasmapheresis session, right at the end, acute hypotension was noted. We quickly went to the bedside. This acute hypotension was refractory to IV pressure boluses and IV fluid resuscitation. And we're going to go through the diagram to kind of get at the underlying etiology of what actually occurred. And as you guys can see on this diagram right here, it's our VA ECMO circuit with the plasmapheresis machine spliced in parallel. So as you all can see, there's a femoral venous cannula return. It goes through our pump, and then blood is sent through an oxygenator, which is pretty standardized, so you all know for VA ECMO. After the oxygenator, some of the blood is returned via the arterial limb. However, with our plasmapheresis machine being in parallel, some of the blood is then sent to our apheresis machine, and then it's returned to the oxygenator, and then returned to the patient. What ended up occurring during this event is that the plasmapheresis bags were unclamped while we were on full support on VA ECMO, and this led to a pressure dearth, so pretty much a delta P gradient that led to all the VA ECMO flow, pretty much all the blood volume of the patient essentially going to our plasmapheresis bags while we're still pressurized, in essence, inadvertently exsanguinating the patient. This was quickly identified once our perfusion technicians came to the bedside, and then we started a massive transfusion protocol. During this, she was intubated and stabilized, and after the problem was fixed and the plasmapheresis bags were clamped, she was neurologically intact. However, just given the poor lung compliance during this massive transfusion protocol, she ended up staying intubated. And I did want to, as you all know, we had severe biventricular failure previously. I'm sorry, the echo images are not showing up on this slide, but we then turned into, because they're supposed to be playing, but we then went from single-digit left ventricular failure to about 30 to 35% LVEF, as well as going from a severe RV to a moderate RV. And the only acute change that we had noticed was this event. Then continuing on, the patient remained to have poor pulmonary compliance, and then was not able to be extubated, so subsequently had a tracheostomy placed on postoperative day 11 when they were also decannulated from VA ECMO. That evening, There was an intratracheal thrombus, which then led to hypoxic respiratory failure and eventually PEA arrest. All appropriate therapies were initiated, and the patient was recovered, got ROS without any neurological deficits. She eventually went to LTAC on hospital day 33, and then was home on hospital day 60. So that has been the eventful course that she has. And as y'all can see here, this is the echo that she had right before she went to LTAC, and pretty much had normal LV function, and the RV was mildly dysfunctional, if not normal. So, putting this case into big picture, for heart and lung transplantation, 24% of our patients develop rejection at some point, despite all the immunosuppressant regimens that we've pioneered over the last 50 years or so. When patients go into acute rejection of allograft function with heart and lung transplantation, 11% of them pass away. This case is the first one that we know to date of where, it being inadvertent, we had whole blood plasmapheresis, and that was the only thing truly in this patient's ICU course as we were trying to treat rejection that actually led to allograft recovery. So it begs the question of, is there a place for whole blood plasmapheresis when you're dealing with refractory acute allograft rejection? And if so, how can we safely study this? Because obviously this case showed that we had some pretty severe complications as this happened. And the last thing of note from this case is it's especially important to know how devices are spliced in or are in configuration with ECMO circuits, whether they be VV and VA, because you can have profound complications. And with this, I would like to thank all my attendings and collaborators, and these are my references. And please, any questions would be appreciated.
Thank you very much.
Do we have any questions from the audience?
Dr. Bhowmik, I might have a question. I'm trained in the Swiss system and not familiar with the FDA regulations. Do you know anything about FDA's regulation about us building in a second circuit into a ECMO circuit? Is this okay for the FDA?
In terms of FDA regulations or not, I'm not sure, but I've known that in multiple places where I've trained, I've definitely seen ECMO circuits have other devices spliced in, in series or in parallel.
Is that something you would not do in Switzerland?
No, it's not allowed to do. In Europe, you're not allowed to build in a second circuit into an ECMO circuit. Yeah.
I see.
Yeah.
And with these, having a second device with these circuits, there are protocols in to ensure that these devices don't have failures. Obviously, if we're putting a new central line in, we would go down flows. All these things are in play. This was an iatrogenic situation where we did root cause analysis and found why this occurred, and that was dealt with. But I've noticed that a good amount of institutions do this policy.
Thank you. Thank you. I just asked my colleague, Dr. Sweitzer, whether she is aware of your manuscript in our journal. We are not aware of it yet. What are your plans with this case?
Great question. Just getting towards the end of my first fellowship, I'm planning on writing it up and submitting it to y'all's journal, if that's okay.
We are looking forward.
Thank you so much.
Thank you. So next is Dr. Rachel Morris from Beth Israel in Boston, presenting a management of acute hypoxic respiratory failure in a patient with tracheal injury. Thank you.
Interesting. Okay. I can just jump in. Obviously, the title, as has already been mentioned, is the management of acute hypoxic respiratory failure in a patient with tracheal injury. This case, I got a lot of help preparing this case from my colleagues, including Dr. Gittens and Dr. O'Gara. You can, or I guess I go to the next slide. Where is the? What's this thing?
Did our first presenter steal our
No, is it
advance?
this thing?
No. Yes, yes.
God, it looks like a shock collar. Okay, and I have no financial disclosures to note. So I'll jump right in. At our institution, we cared for a 24-year-old female with a history of class 3 morbid obesity and recurrent tracheal stenosis, initially acquired following a prolonged intubation. She had been in polytrauma MVC and developed tracheal stenosis from that. She had a prior cricrotracheal resection complicated by reintubations and dehiscence and a lot of other things complicating her airway, but had been prior trached, decannulated, and was presenting as an outpatient for a planned outpatient bronch laser ablation and dilation. Following the procedure, she developed respiratory failure in the PACU and required emergent intubation, which was made difficult by her tracheal stenosis and the recent intervention. And this necessitated intubating her with a 5.0 microlaryngoscopy tube via a laryngeal mask airway. And she was subsequently admitted to one of our medical surgical ICUs. Her course was further complicated by pneumonia with tenacious secretions, which were difficult to manage given she had a very small ET tube size and only a PD scope could go through it. We are at a hospital that doesn't have pediatrics, so PD scopes are very difficult to obtain. Initial settings are listed here, as well as the resultant pressures that we saw on the vent. She subsequently developed recurrent desaturations and decruitment events requiring increased tidal volumes, and we increased the PEEP to 14, which resulted in just rising peak pressures to the low 40s, concerning for further lung injury. Additionally, her PDF ratios fell as low as 52% while on 100% FiO2. And despite bronchoscopy with the PD scope, recruitment maneuvers, and paralysis, her pressures remained elevated and she continued to decline. And in this setting, we had several issues. First was her small ET tube size, which we felt was unsafe to exchange at the bedside. And she also needed to probably have a more definitive airway with tracheostomy, which didn't seem surgically appropriate without covering her with something else and having kind of a backup plan for that. So our strategy was therefore twofold and involved cannulating her for VV ECMO, but also as a protective bridge, but also using esophageal manometry to try and better assess her ventilators. I'll focus for a minute on that latter point. So airway pressures are readily obtained and measured by our modern ventilators, obviously. However, these pressures may not be reflective of the true pressures seen by the alveoli given the contribution of the chest wall, which may be increased given weight from edema, effusions, abdominal hypertension, and body habitus alone. So a given PEEP may facilitate varying degrees of lung recruitment and distension in various patients. Plateau pressures are not adequate to measure these pressures applied along the walls of the alveoli, which are the pressures that can induce the lung injury. So transpulmonary pressures can be measured by the surrogate of an esophageal balloon manometer, where a balloon catheter is positioned in the mid-thoracic esophagus, and this allows us to estimate or to calculate the pleural pressures by comparing the airway pressure and the esophageal pressure measured by the balloon. So this can be used to allow this differentiation of mechanics at play, but is also helpful in monitoring lung stress, limiting peak end expiratory pressures, and therefore avoiding ventilator-induced lung injuries, and monitoring for ventilator synchrony. It's especially helpful in the titration of PEEP, which is applicable to this patient, and is obtained by assessing end expiratory pressures from the manometer. So esophageal pressures are monitored in inspiratory and in-expiratory phases with the goal of tight physiologic range of -2 to +2 centimeters of water with a delta pressure of less than 10 to 12. And the aim is also for an in-expiratory transpulmonary pressure of 0, regardless of the FiO2. So she was cannulated for VV ECMO with a plan to bridge to airway exchange and tracheostomy. So following cannulation, an esophageal manometer was placed, noting an inspiratory pressure of 4.5, while peak and plateau pressures from the ventilator were noted to be 46 and 24 respectively. An expiratory pressure of -6 suggested an ideal PEEP 6 centimeters of water higher than what she was currently set on. Her PEEP was subsequently increased with inspiratory pressures demonstrating safe inflation pressures less than 15 on these settings. She then was able to undergo endotracheal tube exchange and eventual percutaneous tracheostomy, intermittent bronchoscopy. She completed a course of antibiotics and steroids, and following this, she was successfully decannulated from ECMO. So in this patient, frequent decruitment and hypoxemia were encountered in the in the setting of elevated peak pressures on the ventilator. And this was thought to be due to mucus plugging, which required bronchoscopy, which is obviously very difficult through her ET tube. And additionally, ventilator management was based on a reaction to these values, which may have been confounded by a large habitus as well as the narrow tube. This ultimately contributed to the decision to cannulate her for ECMO, and that was coupled, which was when coupled with the need to have some sort of protective bridge to therapy and tube exchange. Once esophageal manometry was utilized, we noted pleural pressures were low, suggesting her lungs were not seeing the actual values that were being reflected on the vent. And the end expiratory pressures actually suggested that she possibly was having derecruitment throughout all of this, leading to increased atelect trauma and actually exacerbating the issue. So this was remedied by the two modalities of VV ECMO as well as the esophageal manometer. And the ECMO gave us the opportunity not only to transition safely to the definitive airway, but also to ensure a lung protective strategy for lung recovery prior to decannulation. And I will pause for questions. Sorry, I don't have a really fancy, fun slide afterwards with Dwight, so.
Don't be shy, guys. Any
Oh, please
questions
be
from the audience?
I've got a question. At which level was the trachea injury? At which it was up or next to the carina, or where was the injury?
The tracheal injury, she had subglottic stenosis from prolonged endotracheal intubation that had happened from a prior hospitalization many years prior, and then had undergone a resection, which is a whole nother event. This poor girl has had multiple issues. When she had a prior cricotracheal resection, she actually had a dehiscence when she had an acute respiratory issue while she was in the ICU, needed to be re-intubated, and had an anastomotic dehiscence. So she's had a lot of recurrent issues with her trachea at this point. So, yeah.
And did you consider inserting a second tube, 5.0, that you place one tube in the right bronchus and the other tube in the left bronchus?
I think the concern was that the 5.0 was the only thing that they could get in the acute setting, and I think there's a picture here that's representative of, it's very blurry and I apologize for this, but just representative of how tight her airway was. So the 5.0 was all that they felt in the initial situation that they could get in. But no, I think the main consideration was that we were concerned that she was having worsening ARDS, that she needed to have some sort of protective strategy so that we could actually exchange the tube and to do the trach. So that was kind of the ultimate conclusion.
Are there situations when esophageal manometry is not going to be able to be used, or it will not be reflective of the lung pressures?
I'm sure that there are, and certainly in certain patients with different surgical issues, it requires being able to safely insert a balloon into the esophagus, and I'm sure if there's, and I probably wouldn't be excited about putting them in a lot of cirrhotics or anything like that where they could have issues with variceal bleeding or things like that. But I think in this situation it was likely to be the best thing for her, and I think in obesity it's probably a really good adjunctive measure because there it's, the contribution of the chest wall and, especially class 3 obesity can be a large contribution, and so you really can't get accurate measurements on peak pressures from your vent.
And does it matter where in the esophagus you place this balloon?
It does, and actually for placement, you're kind of using, we usually use a general idea of like 35 to 45 or like 30 to 43, I think is on average where we place it, but you're looking for those changes in oscillation that are reflective of the heart and then continue to go down. And there's a test that you can do essentially to try and maximize the placement where you're actually giving little chest, I don't know what the word I'm looking for is, like bumps, maybe not a chest bump, but and you're seeing that the airway pressure that's measured and the esophageal balloon kind of do that in concordance without changing that delta P between them, and then you're in the right place.
Thank you.
The audience agrees. We hand over a business card. Dr. Morris.
Do you like my card as well? So maybe we should introduce ourselves, actually. I'm BobbieJean Sweitzer. I'm the executive editor of ANA Practice, which is a sister journal to Anesthesia and Analgesia. And it was originally a journal that was designed for case reports and case series. It was originally called ANA
Case
Reports. Thank you. Now we're expanding our journal. We have already to accept innovation articles, educational articles, quality improvement. In fact, for those residents sitting in the audience, you all have to do a quality improvement. Those in the United States, at least are training, have to do a quality improvement project. And lots of times those are really, really rich, have a lot of rich material that their people could benefit from. And yet they're often, it's hard to find a place to, get those published. So Markus is going to tell you a little bit more about himself and about the journal as well. But that's what we're trying to do here, is encourage you, because these are exactly the kind of cases and information that is actually very rich material for our journal.
Yeah, my name is Markus Luedi. I'm associate editor in BobbieJean's journal. I've been doing this for the last, 6 or 7 years. And when preparing this session, we were looking up the titles and the authors, and we didn't find the submissions yet. So wholeheartedly, we invite you to submit these cases. They are presented here for a reason. And most innovation starts with level 5 evidence. These are the case reports, and this can stimulate bigger projects. So don't underestimate level 5 evidence. It all started there in history, and it still starts there as a foundation for the big trials with single cases.
Yeah, remember, it's not just case reports, but those are very important, as Dr. Luedi, mentioned. In fact, the treatment for local anesthetic toxicity was generated by a case report that was published. And there's a lot of famous cases through the history where it started with a single report of someone observing something and reporting it so the rest of us can learn from that. Should we have our next speaker come up?
The next speaker is Dr. Olivia Zerigano from Stanford University, talking on optimizing airway management, the role of the pre-op endoscopic airway assessment for an anticipated difficult airway in a critically ill patient.
Thank you so much. So again, my name is Olivia Saragano. I'm a critical care fellow at Stanford. Thanks all of you for being here today. I have no relevant financial disclosures, but I should disclose that I am not an anesthesiologist. I'm emergency medicine trained and finishing my anesthesia critical care fellowship, and so I worked with some great anesthesia colleagues on this case. So this is a case of a patient for which we used PEAE, which is the Preoperative Endoscopic Airway Examination, to facilitate establishing a definitive airway in the ICU. So let's start with what exactly is the PEAE. It's an examination of the upper airway using a fiber optic scope to assess for high-risk airway features that may make tracheal intubation difficult or impossible. The structures examined are the base of the tongue, the epiglottis, vallecula, glottic aperture, and larynx, which cannot be evaluated by conventional airway exam maneuvers. In 2011, an observational study performed by Rosenblatt et al. Found that for patients with known or suspected airway pathology, use of PEAE in addition to standard practices resulted in a change in the airway plan in about 1 of 4 cases, but importantly, in 8.5% of cases, patients that were originally planned to undergo asleep airway management were actually changed to undergo awake airway management after the discovery of unanticipated severe airway pathology. This image is from that paper and is an example of one of these cases. This is a patient that had a history of familial polyposis, had multiple prior intubations without any severe airway pathology noted, and on this occurrence of intubation prior to asleep induction underwent PEAE, and this severe laryngeal narrowing was found, and that of course prompted the intubators to change course and plan for awake intubation for airway protection. And so PEAE can help the clinician identify anatomic challenges, but also in patients with physiologic difficult airways, as we often encounter in the emergency department and in the ICU. It can help to provide reassurance for rescue airway techniques, such as the ability to perform mask ventilation with appropriate placement of an oral airway, to properly seat a supraglottic airway, or to place an endotracheal tube awake via a nasal route. So our patient was a 75-year-old man with a history of Parkinson's disease and profound kyphoscoliosis. He was admitted to the ICU in the setting of hemodynamic instability and rapidly escalating oxygen needs. And his most previous intubation prior to ours was 2 years earlier in 2021. And at that time, documentation noted that it required 3 anesthesiologists to appropriately position the patient and to obtain a laryngoscopic view. And at that time, only a grade 3 view was achieved. And at this time in the ICU 2 years later, he had substantially reduced neck mobility, very minimal mouth opening, and his kyphosis limited external access to his larynx for emergency front of neck access. So given these findings, our patient was of course an anticipated difficult airway, both anatomically and physiologically. But the techniques that we used in this case can be applied to cases in which airway challenges may be less obvious. It's well established that bedside airway tests have somewhat poor sensitivity and specificity for the anticipation of a difficult airway. Traditionally, these tests also assess primarily for anatomic features and do less consideration of respiratory compromise or hemodynamics. In 2015, a study published in Critical Care by PEAE et al. Of 1,400 intubations in 42 ICUs found that severe cardiovascular compromise occurred in up to 30% of intubations, and concerningly, these patients had reassuring hemodynamics prior to the induction for intubation. Above is the ASA difficult airway algorithm, which does include somewhat vague criteria for the consideration of awake versus asleep management. An evaluation for these factors, especially the feasibility of mask ventilation or ventilation via a supraglottic airway, may be more completely assessed if adjuncted by PEAE, and it may be prudent to consider this technique early in the algorithm for difficult airway planning. So to return to the airway assessment of our patient, following adequate decongestion and topicalization of the right nair with oxymetolazone and viscous lidocaine, PEAE was performed, which revealed a patent right nasal passage and normal nasopharyngeal anatomy as seen in this first image. Inspection of the nasal passage for size and patency can help to reassure the clinician of adequate space to advance a fiber optic scope for awake intubation and suggest the ability to perform bag mask ventilation in the case of an emergency. Next, the vallecula and epiglottis were examined, which were in this patient effectively normal. And the finding of a vallecula free of masses or obstructions suggests the ability to properly seat an oral airway to assist in masking if that becomes necessary. And it also can typically suggest the ability to perform laryngoscopy, though it's important to note, as we'll again review, that a free vallecula does not necessarily correlate with a grade of view on laryngoscopy. The piriform sinuses and posterior pharyngeal wall were also free in this patient, which suggested the ability to appropriately seat a supraglottic airway if that was needed for rescue. Ultimately, following this reassuring exam for awake management, this patient was intubated with a 6-0 microlaryngoscopy tube, awake and without the need for any intravenous sedation. There was an attempt made to convert this nasal intubation to oral intubation for ease of ICU care, which ultimately failed. We used a GlideScope Mac 3 from the front of the patient and were only able to obtain greater than a grade 4 view. And the flexible intubating scope was unable to be advanced despite the assistance of the GlideScope and an ovosapien intubating airway due to the patient's immobile neck, TMJ, and oropharyngeal soft tissue crowding. And in the event of asleep airway management, orotracheal intubation would likely have been extremely difficult or maybe impossible. I think this case exemplifies the feasibility of using advanced airway techniques such as the PEAE in a critically ill patient with ongoing physiologic derangements and difficult airway features. As this patient presented a clear indication for awake airway management, a personalized airway plan was devised to optimize first pass success and improve patient safety. Predicting the grade of laryngoscopy with PEAE should be used and interpreted with caution and should not discourage awake intubation in the appropriate patient. This patient ultimately was found to have Staph aureus pneumonia and bacteremia and required prolonged mechanical ventilation and ultimately was able to get a tracheostomy. But fortunately, he was discharged home, and when I called him and his wife at home to get their consent for us to present his case here, he was tolerating capping trials and actually asked if there was a Zoom link so he could watch his case be presented.
Oh.
So thank you all for your time, and I'm happy to take any questions. I don't honestly know what they were able to do, even once paralyzed. So at the time that we attempted to exchange his nasal airway for an oral airway, we did sedate and paralyze him, and he had no improvement of neck mobility. It was really pretty profound. So I think just a really bold ENT.
For some reason you weren't able to get nasopharyngeal or oropharyngeal. Did you guys talk about like VV ECMO, whether it be like groin cannulas or like crescent or anything like that? Or?
We talked about his ECMO candidacy prior to all of this, and it was kind of determined in a multidisciplinary discussion that he would not be a great candidate for VV ECMO because of the degree of his comorbidities. I don't know, and I think a lot of that had to do just with anatomically what the challenges would be to be able to cannulate him. Thank you all so much.
Thank you.
Would you like to manage this airway, BobbieJean?
I think you did a bang-up job managing that airway. But I have one quick question, though, or another comment maybe. So another, I think, use of this technique of examine the airway is when you have a patient who's hoarse, or a patient who sometimes we have patients reported, there was a vocal cord problem, or in the past I had a paralyzed vocal cord, and it's been years and no one has seen them. And that is another useful technique that one can use in
Absolutely.
that setting, especially preoperatively if they're going to be intubated, or if they're going to have thyroid surgery or head and neck surgery or something.
And do you would like to manage Dr. Serigano's manuscript?
Yes, I would love
like
to,
to?
actually. I would love to do that, so
So, welcome.
thank you.
Appreciate it. Thank you.
And it doesn't matter that you're not an anesthesiologist, actually. We're very egalitarian. We will take, in fact, increasingly we're looking for perioperative, submissions to our journal. So we welcome submissions from internists, primary care doctors, critical care physicians, that has, a connection to the care of the procedural patient or a patient having anesthesia or in the intensive care unit. But we publish pain, articles around pain management and chronic pain, acute pain, regional anesthesia. So it only has to be sort of tangentially related to surgery and anesthesia. So I think you're doing a bang-up job with these introductions. You keep going.
My
He's
pleasure.
practicing his English, too.
Yeah. Talking about English, we have one request if you submit your papers to our journal. As a non-native speaker, I always wonder what an emergent case is. So, and BobbieJean keeps explaining it to me. What is an emergent C-section, BobbieJean?
I think it's become a very jargon term that we use emergent in place of emergency. Emergent means to emerge, such as worms emerging out of the ground. I always visualize that when I see that word used medically. So Markus and I are particular sticklers when it comes to grammar. It's a common thing, a theme with us. But
So it's an emergency C-section.
it's an emergency C-section.
Okay, thank you
It's
for
an
that.
emergency case. It's a patient having an emergency airway management. Please, we urge you to purge the word emergent. I don't even think of any medical reason to use the word emergent.
Thanks. I'm keen to learn in the US. So, last but not least, it's Dr. Xavier Smith from Vanderbilt presenting novel treatment of bilateral vasospasm secondary to bilateral orthotopic lung transplants using papaverine.
And we know those aren't emergent vasospasms.
Let's see. Right. Hello, everyone. Nice to meet you. I'm a third-year medical student at Vanderbilt. Thanks for giving me your time. As was said, this is the novel treatment of bilateral vasospasms following a bolt using papaverine and axillary catheters. Special thanks to Dr. Harris. Thank you for mentoring me and making this possible. I have no financial or commercial relationships to disclose, and I will not be discussing off-label or investigational use items. So to provide some context, chronic respiratory diseases, things such as COPD and ILD, remain one of the leading causes of mortality globally. Lung transplants have become established treatments for end-stage lung diseases, and approximately 3,000 of them were done in 2023. As such, recognizing common and rare sequelae of lung transplants is important in reducing morbidity and mortality. Here we report a rare finding of bilateral extremity vasospasm following a bilateral orthotopic lung transplant or bolt. We begin the case with a 49-year-old female with a past medical history of ILD, diabetes, and hyperlipidemia without evidence of underlying vasospastic disease, who presented to the CVICU on VV ECMO following a bolt, which was complicated by acute hypoxic respiratory failure. Her postoperative course was further complicated by pneumonia, hypotension, and ARDS, all of which necessitated antibiotics, norepinephrine at 3 mics per minute, vasopressin at 0.04 units per minute, as well as renal replacement therapy and lung protective ventilation strategies. On postoperative day 3, the patient endorsed bilateral hand pain and numbness, prompting the team to get an ultrasound which revealed absent pulsatile flow in the radial and brachial arteries. Bivalirudin and a left axillary block were initiated, and that was followed by an upper extremity angiography, which will be shown here. The relevant finding of the angiography is revealed here. The impressions showed proximal occlusion of the radial and ulnar vessels that was concerning for vasospasm. So the patient was given a 5 milligram and 18 milligram bolus of TPA and piperine respectively, followed by a continuous infusion of piperine at 15 cc's an hour using axillary catheters, which resulted in the resolution of the vasospasm and pain. Piperine is an alkaloid opioid which has strong vasodilatory effects by increasing concentrations of cyclic AMP and GMP. The following is a demonstration of the mechanism of action of this drug. Here you can see that piperine inhibits cyclic AMP and GMP phosphodiesterase, which increases the relative levels of these messengers. And the downstream effect of that is that myosin light chain kinase is inhibited or inactivated, which leads to smooth muscle cell relaxation and vasodilation. Traditionally, piperine is used in vasospastic disease, so things such as post-subarachnoid hemorrhage vasospasm, Raynaud's, mesenteric ischemia. It's been used for coronary vasodilation and vessel harvesting and the setting of cabbages. Traditionally, it's administered as a bolus over 1 to 2 minutes. However, here we employed a continuous infusion using axillary catheters, which to our understanding is a novel therapeutic approach to treating limb vasospasm. The rest of the patient's course was characterized by reperfusion of the limbs. The patient was decannulated from VV ECMO and ultimately discharged home. However, subsequently, she did undergo mastectomies and upper extremity digital amputations due to necrosis, and ultimately the patient was admitted to the ICU for shock, pulmonary embolisms, and bilateral pleural effusions. Unfortunately, the patient succumbed to her illness in April. That's all. Thank you for your time. Happy to answer any questions.
How did you know these weren't clots?
That's a good question. I think based on the angiography and the impressions from the interventional team, the index of suspicion for clots was less so. I think the angiographic impressions were very concerning for vasospastic disorder. And I think it was also evidenced by the fact that it was resolved when they were bolus with piperine.
But you also gave TPA at the same time, right?
They did.
I mean, because the abrupt cutoff, right, was a little bit interesting. One usually doesn't sort of have an open and then such a occlusion with vasospasm, right?
I think another component of the case is that it was bilateral, so the chances that there would be thromboembolic disease in bilateral extremities was probably a little bit lower.
So you're getting some help from the
A
crowd there.
little bit of help.
It's pretty good. We could play this game. What is it, right? Charades? I think could be a lot of fun. No, you did a really excellent job, and congratulations being a third-year medical student standing up here. That is really
Well,
impressive.
Thank you very much.
I have a couple more questions, but Marcus, do you have any?
I've got a question. Did you ever handle a bold case report in a practice?
A bolt?
A bilateral orthotopic liver transplant?
I was struggling keeping up with the acronyms and the abbreviations. If you do submit, we do ask that everybody has a glossary of terms that they include so that we can define all of those abbreviations, because I do realize that increasingly that's the way we all speak and write, in abbreviations and acronyms. But sometimes they're a bit hard to follow. What other question was I going to have? Oh, was there any consideration of doing, I think you did do an axillary block on one side, right? Like, what was the results of that after you did that block?
I think the axillary block provided some analgesia, but it didn't actually address the vasospasm or ischemia, so the team decided to proceed with a continuous infusion of papaverine afterwards.
Yeah, I think we have a question from the audience.
If you were thinking that it could potentially be vasospastic, why not do a stellate gateway block versus an axillary, because you get more of a sympathetic from the stellate gateway block?
That's a really good question. Fortunately, I do not know the answer to that, but I'd be happy to look that up and discuss it with you later.
That's a great answer, always. And then you have to pivot to another comment so they stop asking you questions you don't know. So I mean, that is interesting, because I wonder whether it was just the axillary block was too low also. I mean, even like an interscaling block may have given you better, higher coverage, to intervene or interfere with the sympathetic flow into that. And at least as a test, that would have been interesting. Well, that's, we love novelty, and so you said, as far as you know, it's the first case that was ever where you used axillary catheters to treat this, so.
In a bold patient.
Thank you.
Thank you.
Thank you for attending.
Any questions on any of the presentations? We can bring the presenters back up here again, and you guys can grill them.
No, my understanding is it's not really common anywhere. Upon extensive literature review, there's not really much papers published on it. I'm not quite sure why we need this. I don't know if we actually did calcium channel blockers.
It's often used in cardiac surgery when the cardiac surgeons are afraid that the coronary bypass is spastic. Then they apply papaverine to the bypass. I think the idea might come from there. Yeah.
Cardiac surgery fellow that performed catheters was actually a vascular surgeon in his prior career, and so was used to using papaverine for the mammary arteries and thus using papaverine.
Thank you.
Was it difficult to get, or you guys you had it at your hospital?
We just had it.
I just have another question. Were there any systemic effects from the performing infusion?
No, it was very localized damage.
Any other questions? Well, yes.
Not a question, but I just wanted to let everybody know that not just these 4 cases that were presented here, but all of the medically challenging cases that were submitted for this year's annual meeting will, for the first time, be published as a supplement to A&A practice. That's one of the reasons why we have BobbieJean and Markus up here as the moderators for this. But the IARS Board of Trustees and the Annual Meeting Oversight Committee both thought that the medically challenging cases are too important not to be highlighted, just as all of the other presentations are in the regular annual meeting supplement. So just wanted to mention there is going to be that special treatment, and I don't know if you guys want to talk about the editorial that you're putting together to accompany that supplement.
Well, you wrote it, Marcus. You should.
You were the senior also. Supervising.
I just corrected your grammar in English.
The next days, it should have been this week. It might be next week that it comes up. Have a look at A&A Practice homepage. So we provide a brief editorial about the value of case reports. When it started with Morton's anesthesia in Boston, this was a single case. It's where the entire specialty took off, with the first case described as a case report. And we refer to your 4 cases presented here. They will be cited in this editorial. And honestly, we are looking very much forward to publish the entire case report. So we encourage you to wrap it up in a 1,500 words manuscript. And whenever you need any help or pre-submission inquiries, please just address us, and we are most happy to help.
Yes, we've written a couple of editorials, actually. One already published a couple years ago, one to be published, giving some advice, especially for those new, I guess I could use the word, emerging writers here. You emerging authors out there. You know, it's if you haven't published before, if you're very new to the publishing world, it can be a bit intimidating, I think. And the nice thing about currently our journal, the maximum word count is 1,500. It's very clear if you look for our instructions for authors, the types of articles we accept. The structure is pretty straightforward. There's an abstract, there's an introduction. You know, the basic. We don't accept complex statistics, just typically descriptive statistics if you are going to use those. 1 or 3 tables or figures, and I think it's a nice way to dip your toe into publishing. I have published several case reports and case series with medical students, with residents, and sometimes these people didn't really have that much of an interest in publishing, but sometimes it was just a really great situation or case or a quality improvement project they had done, and they were so excited about the whole prospect, and then seeing their name in print and dealing with the reviews back and forth and the learning experience, that many of them were like, I want to do this again. And they were really energized about having research careers or writing in the future. So it's really a wonderful opportunity to try your hand at it, and we're here to help. And we're more kinder and gentler typically than some of the bigger journals. So I have a few more cards up here if you guys want to come up and get information. We appreciate all your time, and otherwise, I guess we'll let you get to dinner sooner. And there's a reception, right? I think there's a reception in the exhibit hall that starts at 7, right? Is that right, Jason? 7, I think? Yep. So time to go to the bathroom, freshen up, and get to the exhibit hall.